Good afternoon, everyone. My name is Shawnee Van Poeteren and I'm from Advocare. Welcome to today's presentation, the Ready to Listen project, Preventing Sexual Assault in Residential Aged Care. Before we start today's session, I'd like to provide acknowledgement of country. So I and Advocare would like to acknowledge the traditional custodians of the land we meet on today across WA. Here in Perth, I acknowledge the Whadjuk people of the Noongar Nation and pay my respects to their elders past, present and emerging. I acknowledge that the lands we meet on always have been and always will be Aboriginal land. So just a bit of a reminder today that our session features heavily on information around sexual assault and the impacts of trauma. So if you feel like you need to leave the webinar and rejoin or completely leave the webinar, please feel free to do so. So today's session outline is about Advocare and who we are and what we do, defining elder abuse, speaking about the very important Ready to Listen project, talking about the rights and responsibilities of residents and staff, hearing the very impactful and powerful story of Sandra, speaking around the MAP, which is a resource that sits in the Ready to Listen project, around the myths, the facts and practical strategies improving response to sexual assault, and always including resources for further support. So who is Advocare? We are an independent, community-based, not-for-profit organisation that supports and protects the rights of older people in WA. We are funded to provide free and confidential advocacy for older people who are eligible for or who are receiving Commonwealth-funded aged care services. Advocare is also contracted to deliver information and support on the WA Elder Abuse Helpline for those who are experiencing or at risk of experiencing any type of abuse. So who we help? This is our eligibility criteria. So as I mentioned before, it is anyone over the age of 65 that is eligible for or receiving Commonwealth funded aged care services, whether that be in the home setting or residential aged care. We work with people that are able to provide consent. So those with legal decision-making capacity or their legal appointed representative, and the people I mentioned before around people that are at risk of or experiencing any type of elder abuse. There are certain people in the community that we can assist that are under 65. They are Aboriginal and Torres Strait Islander people that from 50 plus can receive support and assistance from Advocare, and also people from 45 plus if they have been deemed to be at the risk of being homeless and are premature aged. So I touched on briefly about advocacy before. So if anyone is receiving Commonwealth funded aged care services and they would like support to resolve any issue they might have, then we can provide them with advocacy. Information, we can provide lots of different information in regards to your rights in aged care, the quality standards, what a provider's obligations are, and just general information in regards to accessing aged care services. We have the CVS program, which is the Community Volunteer Scheme. So that is the community connections for people that are at risk of being socially isolated. We are providing education sessions through the community. We're doing online webinars. We provide face-to-face engagements to anyone that is eligible for or receiving aged care services or pre-access to aged care that just want to know a little bit more about what aged care is. And as touched on before, we provide support and information on the WA Elder Abuse Helpline. Please know that the helpline is available for anyone to call. It's not just the older person. If you are concerned about someone you know, a loved one, someone that lives next door to you, someone you care for, please know that you can call the WA Elder Abuse Helpline at any time and receive advice, information and support around what's going on with the older person. So yesterday was World Elder Abuse Awareness Day. So I just wanted to touch on what WEAD is. So in June each year, we spend a day week organising events to highlight the incredible impact elder abuse has on society. This serves as a call to action for individuals, organisations and communities to bring attention to the issue of elder abuse, neglect and exploitation. So I want to ask everyone a question online. So what do you think elder abuse is? A lot of people have an idea. We get a lot of calls around what people think elder abuse is, and sometimes the definition isn't exactly what the World Health Organization deems it to be. So the next slide is the World Health Organization's definition of what elder abuse is. So that is a single or repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust, which causes harm or distress to an older person. And the WA statistics are that there may be 1 in 20 older people in WA experiencing elder abuse from family and friends. By far and away, when we get calls to the WA Elder Abuse Helpline or Advocare in general, the person that is being abused normally knows the person that is the perpetrator of the abuse. It's someone very close to them. It could be a spouse, it might be a child, it might be a long-term friend or a neighbour. So they're the statistics that we're aware of. But as we get many, many calls about elder abuse, we have decided to put a different spin on what elder abuse is really. So this is Advocare's definition of what elder abuse is. It is a hidden scourge, a taboo subject that has the potential to cause great suffering to nearly a fifth of our nation's population. Elder abuse in all forms causes untold damage and silences the voices of older people. And the national statistics were that 1 in 6 older Australians reported experiencing elder abuse in the last 12 months. What we're really here to do is raise the conversation and make sure that the voices of older people aren't silenced, no matter what type of abuse that is happening to them. So the global research data indicates the following, that only a small proportion of elder abuse is detected. Elder abuse is associated with significant increased risk of mortality. Elder abuse can lead to serious physical injuries and long-term psychological consequences. And people with some form of decision-making disability were more likely to be subject to abuse. All of that ties in with what we're talking about today in regards to sexual assault in residential aged care, but it's true of any sort of abuse that is either detected, not reported, and the impact it has on the individual. So when we get calls to the WA Elder Abuse Helpline, although they're very, very complex, in a way, we simplify them and put them into these 6 categories. So we hear about social abuse, we hear about the neglect, we hear about the financial abuse, the physical abuse and the sexual abuse. Underpinning all of those types of abuse is psychological. So these are the latest statistics that we have from the WA Elder Abuse Helpline. As you can see, we hear more about financial abuse than anything else, and it's filtered down to the physical and the sexual. So that's what I wanted to make mention of now, is because that even though these statistics that we hear about and the people that are brave enough to give us a call and let us know what's happening for them or for someone that they love, that I just wanted to point out that just because there is a significant reduction in the amount we hear about sexual abuse, it doesn't mean it's not occurring. It's just meaning that people aren't reporting it. They don't know how, they don't know if they do, what the impact will be. And it's about opening that conversation because we know it's happening. That's a fact. But we don't know how often it's happening, and we don't know how to help the people that it's happening to. So what is sexual assault? Given that we're talking about sexual assault, what does sexual assault mean? What does that look like? So sexual assault is a type of sexual violence that involves any physical contact or intent of contact of a sexual nature against a person's will, using physical force, intimidation, or coercion. So what sexual assault is the forcing, the threatening, the coercing, the grooming, the stalking, the sexual innuendos, sexually explicit language, showing of pornographic material. It's not. If there's any consent involved and that person has the ability to consent, anything that's consensual is not considered sexual assault, whether that be affection or sexual relations or gesture of comfort. So please know that if there is consent given by both parties, it is not considered sexual assault. So a bit about before we get into the Ready to Listen project, I just wanted to provide an overview of the timeline up to the Ready to Listen project being born and the resources being developed. So in October 2018, there was a Royal Commission into the aged care quality and safety. So the background to that was there was reports from a facility in South Australia called Oakton Aged Care Facility, and there were numerous reports of abuse, neglect, mistreatment and preventable death. They weren't followed up and there were drastic consequences to that. So an investigation was launched and the facility was eventually shut down in 2007, but that is initially what sparked the Royal Commission in October 2018. So after that, there was a prevalence study done by KPMG, and that was around sexual assault in residential aged care. So during that study, there was a survey done to people that worked in residential aged care, and the results were shocking. 58% of people that worked in residential aged care thought that if a person who had dementia or cognitive impairment was sexually assaulted, that there was no trauma, there was no impact because that person couldn't remember what had happened. We absolutely know that is completely different from the information and the findings that we actually do have. So when the final report came to be at the end of March 2021, after the Royal Commission had commenced and finished, there were 588 submissions around sexual assault in residential aged care, and it was estimated at that point that there were 50 sexual assaults occurring in residential aged care each week, and that's what we knew about. So we can imagine that that was much higher, but 50 sexual assaults in residential aged care per week. After that, in April 2021, the Serious Incident Response Scheme was established, and this was an initiative to help prevent and reduce incidences of abuse and neglect in residential aged care facilities. Prior to SIRS being established, sexual assault was only reported if it was a care worker, a family member, a friend. It wasn't necessarily reported if it was another resident and if both residents had dementia or cognitive impairment. So following on for that, they needed more resource, more support, and more information and education around sexual assault in residential aged care. So the fact sheet from the Aged Care Quality and Safety Commission was launched in June of 2021, and that provided a guide for residential aged care providers, highlighting what sexual assault is and the reporting obligations of the provider. And on the back of that, in the same month, the Ready to Listen project was launched, and that was the first federal government funded project to prevent sexual assault in residential aged care. So a little bit about the Ready to Listen project. I would like to firstly acknowledge that it is funded by the Australian government and OPAN is the lead. However, it's in partnership with Celebrate Ageing and the Older Women's Network in New South Wales. At this point, I would like to introduce and welcome Dr. Catherine Barrett. She's an amazing woman, and she's the reason why this project has been so effective. Catherine is the project coordinator for the Ready to Listen project, and she's also the director of Celebrate Ageing and Opal Institute, which is the Older People and Sexual Rights Institute, and has dedicated 25 years to being an advocate for sexual rights of older people and a leader in the prevention of the sexual assault of older women. Catherine, would you like to, because you are the coordinator of this project, give some more depth about the aim and the desired outcome as you
Yes.
said.
Yes, sure, Shawnee. Look, thank you so much for that introduction, and it's really lovely to sit here and hear you talk about this in WA. It's an incredibly important topic. What we found with there was a response to the Royal Commission report. I guess there was a great impetus there. But what we found across this project is a lot of residential aged care service providers are saying to us, we want resources to be able to do this work better. And so many people are saying we don't understand when someone is expressing their sexual rights and they're crossing the line and there's a sexual assault. We don't understand what's happening with sexual consent and where their rights are. And we want to be better resourced to prevent sexual assault. So that's really the work this project has done, is really focused on education and information and resources and trying to build capacity for change. And the interest has been really incredible. Aged care service providers are saying, you know, we want the resources, but also too at home. People are saying we want this at home, and we know that residential aged care aren't the only services that need education and information. You know, we also need information and education for police services and sexual assault services and law courts and family violence services across the board. So I'm really thrilled to be here with you today and to watch the leadership of Advocare on this. It's terrific.
Thank you, Catherine. So to the next slide, some of the resources that Catherine spoke to then will be available to all residential aged care facilities. They're amazing. We have been working with Catherine for the last 6 months and they're incredible. The information and the support that it really does provide for aged care providers is phenomenal. It really is. So we will be sharing all of that and we'll be doing further specific training if required, but please know that the Ready to Listen map is what we will be working with today when we speak about Sandra and her story. And Dr. Catherine Barrett will be speaking to that because she is the genius behind all this information. She'll be able to explain it in a way that I never could be able to. Hopefully one day I'll have the knowledge that she does. So before we get into the rest of the presentation, just wanted to set some ground rules around everyone working here. We acknowledge, we certainly do, because we know ourselves, we've been working on this for the last 6 months and it's a heavy subject. Nonetheless, it needs to be spoken about. So we do acknowledge that this topic of sexuality and sexual assault in aged care is relatively new. And so some challenges exist around discussing the topic. Some people are more comfortable than others discussing this topic, but we do understand that everyone has their personal experiences and their personal beliefs. So just wanted to set a few ground rules before the rest of the presentation. So that is always to make sure, as you would all know anyway, that resident safety is paramount. What we do know, which is just as important, is staff need to feel supported, and conversations about resident vulnerability can be really distressing. We acknowledge that the conversation is uncomfortable and the instinct to lean away from the conversation is what most people's responses are. However, the most effective way to prevent sexual assault is to lean into the conversation and to have that open dialogue with your colleagues, with your management. It should never be a taboo subject, because if it's not brought out into the forefront, then it will remain as such, and there will be more vulnerable people subjected to sexual abuse. Don't let your shock feel like disbelief. The most important thing you do is believe. And that is also, which we will speak to later in the presentation, believe people that report sexual assault, whether they've had dementia or cognitive impairment, a family member. Please believe what is being told to you, because it's incredibly brave for someone to raise their voice and speak of their story. Please, in the first instance, believe what they're telling you. And also, for staff's point of view, to practice self-care. I know during this journey, it has been important that when I'm reading or researching sexual abuse all day, do something for myself to practice that self-care, please make sure that you do that for yourself also. So, Catherine, do you want to speak to the Charter of Sexual Rights and Responsibility? A brief overview of these points.
Yes, sure. And so, Shawnee, this really relates to the issue that I was talking about before, that so many service providers in residential aged care want to know more about resident sexuality and when they need to intervene and when they need to be supportive and when they need to respect privacy and when they need to check consent. So what we did was, at the suggestion of the Aged Care Quality and Safety Commission, we developed a charter of resident sexual rights and responsibilities. And in this document, it also includes the rights and responsibilities of staff, because what we're saying here and what people are telling us is that it's really almost impossible to think about what resident sexual rights and responsibilities without thinking about the rights and responsibilities of staff as well, including and particularly relating to their right to education and information and resources on promoting sexual rights, but also to the right to be free from sexual harassment at work, which is one component of residents who don't understand their sexual responsibilities. So we've outlined, I think there are 8 sexual rights and 2 sexual responsibilities. There they are on the screen now. And there's a document on the charter is up on the OPAN website and is a really useful tool for having conversations in your workplace about the ways that staff feel and think about sexual rights, because so many of us don't think about older people being sexual. We don't think about their sexual rights, let alone our role to play in promoting their sexual rights and guiding sexual responsibilities. So it can be really confronting for service providers, and having a conversation, or as Shawnee said, leaning into, having these conversations matters, because this is the resident's home. They do have sexual rights, and having conversations about rights and responsibilities is a way to build staff confidence in understanding where the line is and when they need to intervene and guide residents. Thanks, Shawnee.
Thank you, Catherine, very much. So after we hear Sandra's story, I just want to introduce you to the map first and foremost. And this is, I suppose, one of the fundamental resources that underpins all the other resources, because this is what we're trying to, I suppose, demonstrate, that there's a lot of people that view sexual assault and the myths that go around that, not actually the facts. And we're trying to dispel the myths in this webinar and with all of our educations and teachings around sexual assault. So I will just briefly touch on what the elements are, and then when Sandra's story is read out in the next slide, then Catherine will speak to the elements and speak to what the myths are, what the facts are, and some of the practical responses or strategies can be, using Sandra as a case study. So this is an outline of all of those elements. So the first one is understanding sexual assault definitions and prevalence, clarifying sexual rights and consent. Number 3 is assessing the indicators of sexual assault. Number 4 is identifying the impacts of sexual assault. Number 5 is complying with reporting requirements, then providing immediate safety and support, practicing open disclosure, providing trauma-informed residential aged care, recognising and reducing resident vulnerability, and protection, prevention, and service improvement. So remember, being ready to listen is about understanding the indicators of sexual assault, believing those who disclose sexual assault, and assessing impacts on the victim survivor, providing support and protecting residents. So I'm going to now throw to my colleague Taryn, who is going to read Sandra's story, and then we'll speak more to Sandra's story and what we can do as aged care service providers to support someone like Sandra if they've experienced similar. Thank you, Taryn.
Thank you, Shawnee. Thank you for having me here today. I just want to remind participants, if they'd like to ask any questions, to just use the Q&A function down below. We'll do our best to get through all the questions at the end. If we don't, our intention is to carry those questions forward to the Q&A session that we have next week with our panellists. We'll also put out an email to let you know when we're going to put a summary of the answers on the Advocare website. So I'll just start into Sandra's story. And just so you know, it's just so that we can step into her shoes and see this from her perspective. If you feel like this is a bit too traumatic, please switch off if you feel you need to and come back. There's also the recording that you'll be able to watch later if you wish to do that. Okay, my mother has always been someone who looked after people. She was a helper. She loved talking to people and she would stand up for people. She had real principles of social justice, but she wouldn't have called it that. She would just stand up for what was right. She loved to exercise. She would swim a kilometre every day. It was one of her main passions. She taught all her family to swim and a lot of her friends as well. She loved cooking and going to a party with the best food. Maybe Mum's sense of justice was instilled in me. Maybe that's why I stepped out of my comfort zone and shared Mum's story. I shared Mum's story for the first time on In Her Shoes project, and I'm sharing it again here because I want to change aged care. I want aged care service providers to understand what it is like from the perspective of a person with dementia who has reported sexual assault. I want service providers to understand that when a person with dementia says that they have been raped, starting by believing the person with dementia is critical to their safety. It is critical to the safety of all residents. It is the legal responsibility of service providers. Not long after Mum was admitted to a residential aged care home, she reported that she had been raped. She reported this on multiple occasions over a week, and the staff filled out a number of incident reports and called in their nurse practitioner, who then contacted us. We were asked to come into the aged care home for a family meeting. At the meeting, the facility manager said they wouldn't allocate any male carers to Mum unless it was an emergency, because she was clearly agitated around males. They said they would keep the door of her room closed to improve her dignity and reduce male contact given the current belief. The term current belief was their perspective on what had happened. They didn't believe her that she had been raped. The staff wondered if she had a urinary tract infection and was confused. A dipstick of her urine was all clear. Despite promising there would be no more male staff continued to provide care, and Mum became more and more agitated with them, referring to them as rapists. Her agitation grew worse. She was causing disruption to other residents. The residential manager told us that Mum had hallucinations of rape. They dismissed her rape disclosure as a hallucination. They did not believe her, and we don't know if they properly investigated if she was raped. We were never told that. When we got copies of her care notes, they referred to her rape ideation. That's outrageous. Rape ideation isn't a term anyone uses in response to a rape disclosure. To say that Mum had rape ideation or thoughts and ideas of rape is dismissive. They were not looking at what Mum was experiencing. They did not believe her. Mum became increasingly agitated, and the staff called in her GP. She had bruising on her arms, and the staff told us that this was self-harm. The Dementia Behaviour Management Assessment Service was contacted by staff to manage Mum's agitation. They were not told that Mum reported that she had been raped. A geriatrician referral was made for a review of Mum's medication, and the geriatrician noted that Mum had been saying she had been raped and asked if the allegations had any background. The geriatrician changed Mum's medication but did not pursue the rape disclosure. The staff did not contact the Department of Health or the police as part of their compulsory reporting requirements at this point. The serious incident response scheme was not in place at this point, but there was still compulsory reporting to the Department of Health. We were not given information about sexual assault services to support mum or us. The local elder abuse services was not contacted. The GP was called and wrote in mum's care record that she had ideas of being raped, but no action was recommended. Mum was prescribed haloperidol to treat her agitation. There was a medication error and she was given a drug overdose. She had 4 doses of risperidone, became psychotic and was admitted to a hospital psychiatric ward. Mum was transferred to the local hospital for her behaviour and treatment of agitation. Her admission record noted that polypharmacy was a significant issue, and staff wrote that she had delusions of being raped and was preoccupied with thoughts of sexual assault. She was agitated on admission and was shackled by her ankles to her bed in the emergency department because she was so distressed. She was given more antipsychotic medication, and the staff queried whether she might have a urinary tract infection. 6 staff held her down to insert a urinary catheter for a urine sample. She was treated for a urinary tract infection. We decided after mum's time in a psychiatric ward, we needed to give mum a break from institutional care. So mum returned to her home to live instead of returning to the aged care facility. Because the aged care home dismissed mum's rape disclosure as a hallucination, we didn't think about her being sexually assaulted either. It wasn't until later that we began to realise she may have been raped and that the service providers weren't taking this into account. We blamed ourselves for not picking that up, but we trusted them to care for mum. We took our cue from them. I wish I knew then what I know now. I know that sexual assault happens in residential aged care and most of the victims are people with dementia. I know that some service providers don't listen to people with dementia who report sexual assault, and that's not okay. Service providers need to listen and respond. People with dementia have the right to be safe from sexual assault in residential aged care. We called the Aged Care Quality and Safety Commission and they investigated. As a result of the investigation, we received a letter from the Aged Care Service which said, "We apologise for not making the mandatory report in a timely manner, and that as part of our continuous improvement program following the complaint, all staff identified as not escalating the concerns has undertaken training on mandatory reporting of alleged and suspected assault." We lost faith in the aged care home and made the decision to care for mum at home. She had good support at home and mum was able to recover from the trauma. It gave us all time to recover from the trauma. A friend put me in contact with a retired senior police officer who agreed to review mum's notes and make a timeline of what had occurred. He contacted the police on our behalf to ask them to investigate the possibility that mum had been sexually assaulted. We had copies of mum's records from the aged care service and noted that some references of rape had been removed. We wanted police to investigate that as well. The police said they would not investigate because mum had dementia, not because of her level of cognition, but because of her diagnosis of dementia. I told them I thought that was outrageous. We got a copy of the police report and it referred to mum's rape fantasies. They dismissed mum's report of rape as fantasy and they clearly needed education as well. There are so many questions left unanswered. Was mum raped? We didn't know. Did the staff, including GP, geriatrician, residential manager, nurse practitioner, general manager, registered nurses and care assistants handle mum's allegations appropriately? No, they didn't. Did the police handle it appropriately? No, they didn't. Mum's rape allegations were never heard. She was never believed. My regret is that I'm unaware of the signs of sexual assault, but it should not have been our responsibility to make sure that the responses were appropriate. but that's not my responsibility to educate service providers and the police about the sexual assault of people with dementia in residential aged care. People with dementia have the right to be safe from sexual assault in residential aged care, and it's our attitudes towards people with dementia that make them vulnerable to sexual assault. If we are not listening to people with dementia who report sexual assault, if we do not believe them, then we are part of the problem. Thanks, Shawnee.
Thank you, Taryn. Thank you so much for reading Sandra's story as told by her daughter. Sandra's story is case in point why this conversation needs to be had and why these education sessions are available and why the Ready to Listen project was created initially. So to speak to Sandra's story in relation to the map, I will hand over to Dr. Catherine Barrett, and I will flick through the slides that will speak to the myths, the facts, and also some suggested responses. So I'll hand over to you, Catherine.
Thanks, Shawnee. I find Sandra's story incredibly powerful, and I think one of the things about Sandra's story when I tell it is so many people say we can do better than this, and absolutely we can. What we're going to do now, so Shawnee has put up on the screen each of the 10 map elements, and for each of the elements there are myths and facts, and there are practical strategies. And what we're going to do is look at how each one of them could be applied to Sandra's care, to look at the opportunities that were missed and how we can improve. And I'm not going to read these out to you, but what I'm going to do is really just provide a bit of a summary. You can come back and watch the film if you want to go through each one of these. But the first map element, we realise that service providers really need to understand what sexual assault is and how prevalent it is. And what happens then when people have this understanding, they're more prepared to respond. If people understand there are 50 sexual assaults in residential aged care a week, people are more likely to respond than someone who thinks that sexual assault in residential aged care never happens. And so this is a really important fact. And I think the other thing here as well too is understanding what sexual assault is, what the definition of sexual assault is. Now, we use the term sexual assault, but the Aged Care Quality and Safety Commission uses the language unlawful sexual contact and unwanted sexual contact, or something similar to that. But the difficulty people have remembering this means that we just quite simply use the term sexual assault. We have the same definition of it, what it means, which is really anything any sexual conduct or contact that a resident doesn't agree to or consent to, any sexual contact or conduct between a resident and a staff member, regardless of whether or not there is consent, and then grooming comes into that as well. So the big questions, and I think reflecting on Sandra's story, is how does your service clarify what sexual assault is for staff? And when we think about Sandra's story, if the staff understood that sexual assault is the reporting of sexual assault needs to trigger a response, then that could have meant that when Sandra said she was raped, that staff said, okay, well, we need to take this more seriously. So that's incredibly important there. Thanks, Shawnee. And so really it's about providing staff with the education and information, and as part of the Ready to Listen project, we've developed some posters for staff on reporting that include a really brief definition of sexual assault as well. Thanks, Shawnee. The second one is around clarifying sexual rights and sexual consent, and this is incredibly important, as I said earlier, that we don't understand a lot of people don't understand that residents have sexual rights, and that the sexual rights of one resident don't mean that they don't have sexual responsibilities as well. And in asserting their sexual rights, they don't have the right to infringe on the rights of other residents. And so there was some speculation that in Sandra's case there was a resident who was wandering around and had perhaps gone into Sandra's room. And so she has the right, in the charter, she has the right to be free from sexual violence or sexual contact. And it's really important for staff to understand that this is a right that she has and that in this case has been violated. Thanks, Shawnee. And so in relation to Sandra's care, we'd be saying we need to actually go back a step and give staff education on sexual rights and responsibilities so they don't just understand sexual assault, but they understand that broader context of sexual rights and responsibilities as well. Thanks, Shawnee. The third one is around assessing the indicators of sexual assault. And this is, I think, where there were real gaps in Sandra's story. There is an assumption in the broader community, or we know that in the broader community, when someone's sexually assaulted, quite often the indicators of sexual assault will be a verbal report. So someone will tell you that they've been sexually assaulted, and there will be physical indicators of sexual assault. In residential aged care, because the victims are very frail, unlikely to communicate, they're unlikely to be able to tell you that they've been sexually assaulted. And the indicators of sexual assault, the research tells us, particularly with people with dementia, particularly for people like Sandra, the indicators are much more likely to be behavioural. And often family members will say, I just knew there was something different. And so it's quite often, particularly if someone like Sandra can't communicate as well verbally as she used to, she was able to say that she had been raped, but she wasn't able to provide more of a description than that. And so she became really quite agitated. And that wasn't picked up as being a sign or an indicator that she had actually been raped. And in fact, Sandra's family said that they took their cues from service providers who said, you know, she's saying she's been raped, she's clearly agitated, so we've increased her sedation. But in actual fact, what we know now is that if somebody is saying they've been raped and they are agitated, both of those things are an indicator that they may have been sexually assaulted, and that needs to be looked at. And in this case, it appears to have been missed. Thanks, Shawnee. And I think one of the really important things there is to say, you know, why do you think staff miss those indicators? And really it's about the lack of education. We've really got to shift that. The fourth element is around the impacts of sexual assault. And what we know from the research, as Shawnee said earlier, is KPMG research showed 58% in 58% of incidents, staff thought there were no negative impacts on the victim. So how do staff prioritise preventing sexual assault or prioritise support for victim survivors if they don't think that sexual assault has a negative impact? And so in a way, it feels like that same myth about pain management. You know, in people with dementia will tell you, or there's research that shows that people with dementia get less pain management than people without dementia. And it's because there is a myth that people with dementia have pain and won't remember, and they don't feel pain the same way. And we know that that's a myth. And we know that it's also a myth that people with dementia, you know, they won't remember or they don't get distressed. And that's actually not a justification for not doing anything about sexual assault. Whether or not a person can remember is not a justification for allowing sexual assault to occur. We need to understand that the research actually shows that people with dementia can have that emotional experience. They can feel the distress of the trauma they've experienced without being able to verbalise, this is what happened to me. And so PTSD, the evidence shows as well too, PTSD can be quite prolonged for people with dementia as well too. So some of the key implications for improvement here are really around educating staff to understand the impacts of sexual assault, and then really exploring with service providers as well too. Why do you think that people don't understand that sexual assault is devastating to people in residential aged care? Why is that myth? I mean, I think it's something that is really quite ageist and ableist, that we think that it doesn't affect older people in the same way. Thanks, Shawnee. And so the fifth element is around reporting. And what we know reporting has changed quite a lot in residential aged care since the introduction of SIRS. And if you look at the Aged Care Quality and Safety Commission's fact sheet on reporting sexual assault, they're really clear in that fact sheet that sexual assault needs to be reported to SIRS within a 24-hour period, before a 24-hour period. And what we found was there were some complexities around reporting to the police. There is not a lot of clarity. There are guidelines that say the Commission's guidelines say that sexual assault should be reported to the police if there's, reasonable expectation that this is of a criminal nature. I haven't been able to find anyone who understands what reasonable expectations of a criminal nature means. So we've developed some guidelines for this Ready to Listen project to outline the times when sexual assault would be or could be reported to the police. And it's actually really quite complex, and I'd encourage you to have a look at those guidelines. In some circumstances, residents have the option to report to police, and in some occasions they don't as well too. I think sexual assault by a staff member should always be reported to the police. And I think in this case, where Sandra is reporting sexual assault, continuing to report sexual assault, what the police are recommending to us is you can ring the local police station and say, this is what's happening, and ask for their recommendations. So reporting is incredibly important. And I think organisations, it can be incredibly beneficial to having guidelines for reporting so that staff on the front line, staff in the direct care, providing direct care to residents, understand who to report to internally and what would trigger a report internally. So in Sandra's situation, if a staff member, if a resident, Sandra has said, I've been raped, I believe, it would be incredibly important in that situation to report immediately internally and trigger a response in the organisation, and be really clear with staff around when that occurs. Thanks, Shawnee. Thank you. We'll move on to the next one. The sixth element of the map is safety and support. And across 25 years of doing work around preventing sexual assault of older women in particular, I found very few residents in aged care that are ever offered information on sexual assault services. Sexual assault services play an incredibly important role in supporting victim survivors of sexual assault. The language they use, the understandings they have, the experience they have means it can be incredibly powerful to have somebody say to Sandra, for example, I'm sorry that happened to you. It's not your fault. We're going to take steps now to make sure that you're safe. And even for a resident in Sandra's position who may not be able to attend a sexual assault service, you may also have a sexual assault service that can't attend the residential aged care service. What I would be doing in that situation, given Sandra has really supportive family, is offering a sexual assault service to Sandra, contacting the local sexual assault services and asking them whether they can provide even a phone connection with the family there, and having that conversation with Sandra so that she can help to process the trauma that she has experienced, because we know that the research shows that people who don't have that trauma support have difficulty recovering from the trauma of sexual assault. And, Sandra's family talk about her 6 months of not settling, 6 months of it didn't matter what sedation they gave her, she wouldn't settle. And it may be that she didn't settle because she was still fearful of being raped. She was still fearful of that sexual assault, and she wasn't being supported to process that. So that's an incredibly important strategy here. And the other one is understanding as well too that this is a project that is being led by the Office of the Public Advocate, and Advocare in WA, they've done the education, they're absolutely on board. And so you could say to Sandra's family, can I give you the number for Advocare? And they can support you to help make sure that Sandra's needs are being met and that she not only is safe, but that she feels safe as well. Thanks, Shawnee. The next element is open disclosure. And this was, again, a suggestion of the Aged Care Quality and Safety Commission. They suggested to us that that we could develop an open disclosure framework specific to sexual assault. And what I get from this is two things that are really unique to this element. And the first one is an apology. And so often families who approach me who are really traumatized will say to me, we feel like no one's listening. You know, we've spoken to this person and this person and this person, as did Sandra's family, and they felt that no one was listening. And when they eventually got an apology, they'd had to fight for 6 months for recognition that a sexual assault might have occurred. And when they got an apology, it sort of almost felt like too little too late. And what the Commission is saying in their guidelines, and we're saying in ours for sexual assault, an apology should be provided from the most senior person as soon as possible. And a sexual assault, an apology is not an admission of guilt. It's not saying we're taking legal responsibility. What you're doing is expressing your compassion for what Sandra has said she has experienced. And what you're doing as well too is saying to the family, I am listening. And being able to say, I am sorry to hear that. I am sorry that happened. I am sorry your mother is distressed, is also a great prelude to saying, and now we're going to listen and see what we can do to create change to stop the sexual assault from reoccurring. And that's the other element of open disclosure, is you're really looking to say, well, what happened here? And not in, as Sandra's family were saying, how can we try and sedate Sandra so that she stops calling out that she's raped? There is an opportunity here and an imperative to say, how can we understand what's happening here? How can we check to see, you know, whether Sandra was sexually assaulted, and how can we make sure that Sandra is safe and that she feels safe? How can we learn here to make sure that this never happens again to Sandra or to any other resident as well? The next element is trauma-informed residential aged care. And this was a suggestion. So many services, when we spoke to them, they didn't call this trauma-informed practice. But what they were saying is, we need an approach that helps us to understand that sexual assault is traumatic for the victim's survivor, for the resident who has been sexually assaulted. We need to understand the impacts of sexual assault on them. But we also need to understand that sexual assault is really traumatic for other people as well too. We know in Australia that 1 in 4 women have experienced sexual assault, I think before the age of 15, is that the stat? So many of us have either experienced sexual assault or we know someone that has. Most of us care about sexual assault, and to have a resident that we're caring for report sexual assault, it's not only traumatic for the resident and their family and the other residents too, who are worried about their sexual assault, it's also traumatic for us as service providers. And so trauma-informed responses say, how do we acknowledge that? How do we take that on board and create change and a supportive environment here? And so what we've done with a trauma-informed resource on responding to sexual assault, we've said one of the key things that service providers can do is sit down with staff. When Sandra's reported sexual assault, is sit down with staff and check in and see how they're going. What do they need? How are they feeling? And often in these circumstances, when you've got staff who are compassionate, it's incredibly important to say, do they need EAP? You know, have you got an employee assistance program and staff can have professional debriefing or counselling? Or do they need to call 1-800-RESPECT and debrief to somebody, you know, immediately? And so what are the ways that we can provide that support to staff? And then when we've done that, we can then say to staff, what happened here? And how can we do things better here to, you know, for Sandra and her family, but for other residents as well too? How can we improve? And when we're doing that for staff, when we're listening to staff in that way, when we're supporting staff in that way, we're showing staff what we're expecting them to do for residents. It's really, really hard to ask staff to listen to residents when they're not being heard themselves. And so the trauma-informed approach is a really practical way of saying, let's listen to staff, let's listen to residents, let's respect staff, listen to their expertise, listen to their experiences, and provide them with the support that we're asking them to provide to residents like Sandra. Thanks, Shawnee. The next one is around recognising resident vulnerability. And I think when I first started developing this map, I thought that that resident vulnerability was about understanding the victim and the perpetrator characteristics. I thought it was about understanding that most victim survivors of sexual assault in residential aged care are women. They're mostly frail, they have dementia, and they have difficulty communicating. And most perpetrators are male. It could be staff, it could be residents, it could be visitors, family members. And I thought if we could understand the characteristics of the victim and the perpetrator, that would be what we needed to do. But the further into this work I've got, the more I understand that actually what makes people in residential aged care vulnerable to sexual assault is our attitudes to older people, not just in residential aged care, but in the broader community. Our attitudes to older people and older women. So we have a Me Too movement, and we had a March for Justice movement in the broader community that was saying we need to say no to the sexual assault and sexual violence that women experience, but there wasn't a focus in that on women, on older women. And we have a whole focus, there are a whole range of services that are focused on sexual violence and sexual assault of women in particular, but also trans and gender diverse people. And we know that some men experience sexual assault as well. But they're not focusing on older women. And in the police guidelines on sexual assault, they're not focusing on older people. And family violence services, by and large, not always, but generally speaking, not. So there's this attitude in the community that sexual assault isn't something that happens to older people. And because of that, we have a culture, I think, in residential aged care where we have not said, let's make this a priority. We've not given residential aged care service providers the resources and education to create change. And that's what makes people like Sandra vulnerable to sexual assault. And Kate Schwaffer says, and Sandra's family have said, if we don't understand that our attitudes make people with dementia and women in particular in residential aged care vulnerable to sexual assault, then we're part of the problem. Thanks, Shawnee. And the final one is about protection and prevention. And what we're saying here is it's not always about, responding to, we need to respond immediately when Sandra reports that she's sexually assaulted, and we need to see how we can prevent sexual assault of Sandra immediately and any other resident in that aged care service at any point in the future from, whoever is perpetrating the sexual assault. But we need to actually take a step back and go, it's not just about responding to sexual assault when it occurs, it's having processes in place to prevent sexual assault from ever happening. I speak to so many service providers who say to me, we are so lucky we don't have sexual assault in our service. And I say, it's not about luck. It's about organisational processes and about education of staff, and it's about having policy to put strategies in place to prevent sexual assault. That's what it takes to prevent sexual assault. And that's what we've done with the Ready to Listen resources. Thanks, Shawnee. And I think that that's it from me.
Thank you so much, Catherine. That was an amazing, very informative and very powerful overview of the map and a real explanation of how it can be applied to anyone living in residential aged care that discloses any incident of sexual assault. So further support, I'm not sure, Catherine, if you want to speak to any organisations that we haven't got on this list. I was focusing on WA in regards to Sexual Assault Resource Centre, obviously the WA Elder Abuse Helpline. I know 1800 Respect and the Commission and OPAN are obviously national peak bodies. Also, during this research, we have discovered that there is a Centre for Women's Safety and Wellbeing. And they have a lot of amazing agencies, even through the regional and remote areas, that can provide support and assistance in regards to sexual assault. Catherine, have I forgotten anything there?
No, I don't think you have. I think that just the other idea is for people to access the Ready to Listen resources on the OPAN website.
Absolutely. Thank you so much. Just a takeaway message in regards to this session. We did this in the community session yesterday. So we were thinking about, you know, empathy versus sympathy. And it's basically what drives the trauma-informed care, underpins everything. And I don't know about you all, but when someone is going through a hard time, whether it be sexual assault or not, they just want to be listened to and supported. They don't want people to feel sorry for them. They just want to feel supported. So delving into that a bit more, it was that empathy fuels connection while sympathy drives disconnection. And those fundamental qualities that you can see there, that perspective taking, you know, taking on the perspective of the other person and recognizing their perspective as their truth. It might not be what you believe, but it's their truth. So listen to them and support them the best way you can. Don't judge what they're saying, just listen, and recognize that emotion in other people and then communicating that. That's those trauma-informed responses. I hear what you're saying. I understand what you're saying to me, and repeat back to them so they know that you're actually actively listening to what they're saying to you. It's hard to have those difficult conversations, and often what we do is to try and make things better. We want to make, you know, people's lives better, for us to take away the pain and the hurt, and that's just not, you know, always appropriate, and it's not even doable in most cases. So the easiest way to go into a situation of sexual assault and supporting people is to have that drive of empathy. And the easiest way to remember the difference between sympathy and empathy is feeling with people, being there, standing beside them, feeling with them, and sympathy is feeling for people. I don't know if that information is useful to anyone, but I thought it was incredibly powerful, so I wanted just to add that at the end of the presentation. So I would like to thank you all for joining us today. I would absolutely like to thank Dr. Catherine Barrett for joining us, and my colleague Taryn for reading out Sandra's story. And to let you all know, and I know that I can see a few icons for the Q&A and the chat. I'm sure Taryn has had a look at that, see if we can respond now. But if not, we will respond to you at a later date. But please know that if you haven't asked anything here and you go away for the next week and you think about what you could possibly ask, or there's something that you want to know, please know that next Wednesday, the 22nd of June, we're having a Q&A panel here at the Parent Centre in the Theaterette. So if you would like to come in person, please register for that, or there's an online option as well. Sometimes when we talk about confronting subjects and it's quite traumatic for the person at the time, it takes a while to digest the information that has been provided. So please know that if we haven't been able to answer any of your questions today, which we'll endeavour to do now, then please know that you are more than welcome to join us, and I encourage you to do so in a week's time. So Taryn, can I throw to you now, please?
Yeah, thanks, Shawnee. We've had quite a few questions. I will go to, because we're running out of time, I will go to the most commonly asked question, which is, will the slides be available for later?
Karen, absolutely they will be. We are going to send the slides through and any related information, like Catherine spoke to, all the resources that were available. Catherine, are they currently all available on the OPAN website, or are they some in draft form still?
There's some in draft form, but most of them are up. The charter, so on OPAN's website, the charter's up. The map is up, the dementia resources are up. So there's probably about 10 resources up there already.
Okay, perfect.
Awesome. All right, we'll go on to another question. Can Advocare support people who have been assaulted in a residential aged care facility who do not have legal decision-making capacity and have a guardian?
We absolutely can, Taryn, because we've been client-centred or client-directed. If the client no longer has capacity, we will always work with the guardian to support them the best way possible. So yes, we will work to support the client with the consent of the guardian.
Okay, thank you. And we've also got, what happens if the person cannot speak English? How can they be supported?
With anyone that calls Advocare, then we will engage the local interpretive service and we will support them that way, should they provide us consent to do so.
Okay, thank you. So I think we've just hit over the mark now. So if you just want to wrap up.
Thank you, Taryn, very much. Like I said, everyone, thank you very much for tuning in. We will get back to you with the questions that we haven't been able to answer today. I wanted to say another thank you to both Dr. Catherine Barrett and Taryn for your wonderful counsel and information today. And yes, please just know that if you have any further questions, that you can bring them to the panel next week on Wednesday, the 22nd of June. Thank you very much, everyone, for attending.